The NIH estimates there are 22 cases of polycythemia vera in every 100,000 people. PV is a blood disorder that causes an elevated number of circulating red blood cells, or cells that deliver oxygen to the body's tissues or organs. It can occur at any age, but it's more common in those over 50. PV is caused by an overproduction of red blood cells by bone marrow due to increased erythropoietin, a hormone produced by the kidneys to initiate the red blood cells production. There are two types of PV, primary and secondary. Primary PV is a result of abnormalities inside the bone marrow, whereas the secondary PV originates outside of the bone marrow. Primary PV is genetic, so physicians can carry out the genetic test to look for mutations in the gene that affect the bone marrow and blood cells, such as JAK2, to differentiate the two types.
One way to diagnose PV is to obtain a blood sample from a patient and determine the hematocrit percentage. Hematocrit measures the percent volume of whole blood that is occupied by red blood cells only. The normal hematocrit range for men is 43 to 49%, and 36 to 45% for women. Elevated hematocrit levels are indicative of PV, which can rise to as high as 70%. Another way to diagnose PV is by determining the hemoglobin concentration in the patient's blood. Because oxygen is poorly soluble in blood, it binds to hemoglobin to meet our oxygen demands. Normal hemoglobin saturation in the blood is 15 grams per 100 milliliters. Levels greater than 15 are commonly associated with polycythemia. Increased red blood cells can lead to elevated blood viscosity, which measures the thickness and stickiness of the blood. High blood viscosity can restrict blood flow through narrow capillaries and increase vessel resistance, or the force that opposes blood flow. Therefore, the heart has to work harder to pump blood, which can lead to heart failure if left untreated.
The elevated RBC count in PV increases the risk of thrombosis, which is blood clot formation within vessels. These clots can obstruct blood flow and lead to serious cardiovascular events like stroke and heart attacks.
In Lamrani et al., researchers used PV mice models to assess the role of JAK2, a mutation present in more than 95% of PV patients, in restricting hemostasis, which is the process that stops bleeding from a damaged blood vessel. They hypothesized that the JAK2 mutation decreases platelet plug formation time.
To test this, adult and fetal mice with the JAK2 mutation were observed. An incision was performed on the abdomen to expose the mesenteric vessel, which provides oxygenated blood and nutrients to the intestines. A rhodamine 6G dye was injected into the vessel to stain for blood platelets, and ferric chloride was applied to induce the formation of a blood clot. Video images were then recorded until the end of the experiment.
In Figure 7a, mutant fetal mice are represented as Ki. A buildup of platelets starts within 6 minutes of injury. In wild type, this platelets accumulation begins slowly at 90 minutes after injury. In Figure 7b, mutant adult mice are represented as TMD60. Platelets accumulation begins quickly within 3 minutes after injury. In wild type, this slowly begins at 9 minutes after injury. At 15 minutes, the thrombus is destroyed, as shown by the white arrow.
In both fetal and adult expression of PV in mice, the formation of the thrombus begins very rapidly, within minutes of injury compared to the controls. Complete blockage of the vessel or occlusion was also quicker in PV mice. Overall, these results suggest that PV has a role in speeding up blood clots.
Symptoms include lightheadedness, fatigue, dizziness, blurred vision, excessive sweating, burning sensation on the hands, concentration problems, ringing of the ears, and itchiness. There is no cure for PV, so treatment is aimed at mitigating symptoms and reducing the risk of complications. The most common treatment for PV is receiving frequent blood withdrawals. If this alone does not help, a doctor may prescribe an oral medication called Droxia to reduce the number of blood cells in the bloodstream and keep blood viscosity closer to normal.
Other drugs may interact with Droxy. Tell your doctor about all allergies and medications and supplements you take, as it may increase your risk for serious side effects. Do not take Droxy if you're pregnant, nursing, or planning on becoming pregnant. Avoid Droxy if you have a history of liver disease, kidney disease, HIV, or bone marrow disorders. Side effects may include nausea, vomiting, loss of appetite, mouth sores, diarrhea, constipation, hair loss, and weight gain. Stop Droxy and tell your doctor right away. Experience hives, difficulty breathing, swelling in your face, lips, tongue, or throat, severe dizziness, numbness, skin ulcers, and sudden chest pain. Ask your doctor if Droxy is right for you.